now we go to the next talk, that is speech pathology by Harrison Jones, and he's working at Duke University.
Thank you. All right, so I'm going to talk about current understanding of speech impairments and Pompe disease. I want to thank the AMDA and the IPA for having me and putting on this incredible event. It's always inspiring to be here, so thank you. My data that I'm going to talk about today are really focused on children with Pompe disease, but I think I have some insights about adults with late-onset Pompe disease as well. These are my disclosures. So as a little bit of a review or an introduction perhaps, just want to talk about the speech and swallowing structures. So when we think about speech, we really need to consider the various structures, the speech subsystems that contribute. So these would include the respiratory apparatus, like the diaphragm, and the muscles of the chest wall and abdomen. The phonatory system, mainly the larynx and vocal folds. Weakness of the vocal folds causes voice quality abnormalities. Moving up forward, up a little higher, we have articulation. Here we're thinking about structures like the tongue, lips, face, and jaw. Weakness in the articulatory mechanism may lead to just speech sound distortions, slower articulation rate. And then finally, resonance. These structures here are going to be the velum, the pharynx, the velopharynx. Weakness here leads to hypernasality with speech. And we really need to examine all these things at the same time when we're considering speech function. So that's what we attempted to do here. So we're doing a combination here of auditory-perceptual methods as well as some more physiologic measures. And so on the left side of the screen, we see articulatory precision, voice quality, and resonance balance. And these were rated by expert listeners using a 0 to 100 scale, a visual analog scale, in which 0 indicates profoundly impaired and 100 indicates normal. And so expert listeners would rate articulatory precision based on a speech sample as very severely impaired, again 0, all the way to normal being 100. We also, again, used a variety of physiologic measurements to complement these. Things like maximum tongue strength or tongue pressure, nasalance, which is an instrumental measure of energy from the nose compared to the mouth, so kind of an indirect measure of hypernasality. A variety of acoustic measures and sustained vowels, as well as articulation rate with speech diodocokinetic tasks, so repeating a consonant vowel sequence over and over, and sentence repetition. And then we also calculated the percent consonants correct, or the PCC, as well as the presence of cleft palate speech characteristics, or CSCs, in consonant vowel consonant words. And so these are some of our findings. So these are specific to voice quality here. And so by voice quality, we're really thinking about laryngeal function. So in the individuals, there were 11 individuals with infantile-onset Pompe disease. The visual analog scale rating was a 42.6. So again, 0 being profoundly impaired, 100 being normal. 42.6 indicates pretty severe voice quality abnormalities there. You can see the really large standard deviation as well as that range. The scores ranged from 8.6 to 95.6. So a really large range there. We found that voice quality abnormalities were present in both groups, but they were more severe in children with infantile-onset Pompe disease than those with late-onset Pompe disease. We saw some acoustic changes in the infantile-onset Pompe disease, with the LH ratios being increased in 8 of the 11 individuals, and this showed less acoustic energy above 4,000 hertz. And so in summary, in the infantile-onset Pompe disease group, we see that voice disorders or dysphonia are common. And we've found this before in prior studies where we found 94% of our participants had dysphonia. Now, in this study here, this involved 4 individuals with late-onset Pompe disease children, and we can see the VAS rating was an 86, with a much more narrow range from about 79 to 91, which would suggest that voice quality abnormalities are much more uncommon and much less severe in individuals with late-onset Pompe disease compared to those with infantile-onset Pompe disease. My clinical experience, though, suggests that in adults with late-onset Pompe disease, we do see voice quality abnormalities a little bit more common than would be suggested here. Kind of in summary here, I think it's important to remember that voice quality impairments are common in Pompe disease, or what we call dysphonia. These are likely exacerbated by respiratory muscle weakness. It's really hard to decouple the laryngeal apparatus and the respiratory apparatus, and it's likely that the respiratory muscle weakness we know exists in Pompe disease contributes to some of these voice quality abnormalities in Pompe. And then in late onset Pompe disease in adults, what I commonly see is that abnormalities in voice quality may be the primary speech impairment that we see. So moving forward to resonance balance here, really, talking mainly about hypernasality. I think that's the words that we hear so often when we're talking about speech in Pompe. And so with resonance balance, we're really thinking about velopharyngeal function. And so when we speak, the velum, the velopharynx, elevates knees back to close off the velopharyngeal port so things do not escape through the nose. Air does not escape through the nose. But in Pompe disease, the velopharyngeal weakness also often leads to velopharyngeal insufficiency, where we don't see complete closure there. So our data here show that the visual analog VAS rating was 51.6, so pretty moderate in the infantile patients. And these range from about a 13 or 14 to 91. So again, tremendous variability in how much resonance imbalance we perceived as listeners. It's important to say that it's auditory-perceptual assessment of speech is really the gold standard, and we use physiologic assessments to enhance our understanding or to complement those data. Ultimately, speech disorders really live in the ear of the beholder. And again, we use the physiologic measures to help explain those and provide more information. But we would never use the physiologic measures like acoustic measures of speech performance in isolation to say whether or not speech was impaired. Again, that's going to be in the ear of the listener. So in the children with infantile-onset Pompe disease, we see mild to severe hypernasality. We saw that cleft palate speech characteristics were very common, such as production of weak pressure consonants or having vowels that were nasalized. Whereas in the children with late-onset Pompe disease, the VAS rating of a 97.1, there was no hypernasality present. And so one of the interesting things we found, though, was that when we measured nasalance, again, this is a measure of the ratio between nasal energy and oral energy, we see, so on the left side, these are the nasalance scores for children with infantile-onset Pompe disease, so they're very elevated, and these were correlated with hypernasality. Now, in late-onset Pompe disease, these children here, we see the nasalance values are elevated, but this did not result in perceptual hypernasality. And so this would suggest that there is an element of velopharyngeal weakness present in those participants, but that it wasn't severe enough to lead to perceptual hypernasality. This is an important finding. Like a Polish researcher, Scalani, he found this before and reported hypernasality in late-onset Pompe disease, but it wasn't perceptual hypernasality. It was just this observation of increased speech energy escaping through the nose that likely didn't result in perceptual hypernasality. And then we also looked at articulatory precision in these patients. So orofacial function here. The VAS ratings here were pretty severe with a 43.8 and a very large range from 5.1 to 97. We found the articulation rate and maximum tongue pressure was lower than in late-onset Pompe disease. So like lingual weakness, for instance, could very likely lead to a decrease in articulation rate. And we found that the percent consonants correct were reduced in 9 of the 11, and they had scores below age expectations. The late 8 phonemes were the most commonly affected, like final L and S, K, And 9 of these 10 infantile-onset Pompe disease patients had tongue weakness. In our 4 LOPD participants here, we see that articulatory precision was preserved with a 95 VAS rating, and 3 of the 4 had tongue strength in the normal range. And we found that the PCC scores, percent consonants correct, were highly correlated with the visual analog scale ratings of articulatory imprecision. And then finally, we looked at speech severity. So again, the expert listeners made judgments on how severe speech was affected. And in infantile onset Pompe disease, that was 38.1, a very large range again from 5 to 88. And so in these children, speech was mild to moderate, mild to severely affected across these participants, compared to the 4 individuals with late onset Pompe disease really had minimal to no speech impairment. When we looked at these data closer, we found that the VAS scores for articulatory precision and percent consonants correct were significantly related to overall severity. And this was surprising to me because of how prominent hypernasality is in Pompe disease. But it seemed as if our listeners were really attending closely to articulation errors when they were assessing severity of speech dysfunction. We have a little bit of longitudinal data that we have not yet published, but for the most part, we're not seeing a large change in speech function from 0 to 24 months. We're not seeing changes over time that are very substantial. So just some conclusions. When we think about assessment of speech in Pompe disease, we really have to measure speech comprehensively. We have to look across all speech subsystems at minimal voice quality, resonance balance, and articulatory precision. And we really need to use our auditory-perceptual methods that are complemented or combined with physiologic measures to help understand what we're hearing. The underlying mechanism of speech impairments in Pompe disease appear to be weakness, orofacial weakness, velopharyngeal weakness, laryngeal weakness, respiratory weakness. I'd also like to advocate for speech-language pathologists being part of a strong multidisciplinary team for Pompe disease and certainly at expert centers. We need more data here on children and adults with LOPD in particular, changes over time, and the effects of activity limitations, the effects of speech disorders on activity limitations and participation restrictions, like we might obtain with patient-reported outcome measures. I think ultimately that careful documentation of speech impairments and related measures may contribute to differential diagnosis, but really more assessment of the effects of new therapies and increased doses in enzyme replacement therapy, for instance, may be important to include in future clinical trials. Thank you very much.